I swear this is the very last time you guys are going to see me up on the stage. Just bear with me for another 10 minutes and we're going to go through another talk about an imaging study. It won't be as comprehensive or advanced as the one you guys just sat through. I'm a simple cardiologist. So we're going to talk about PET, or positron emission tomography, which is a new way of imaging blood flow to the heart, and it has several advantages. Ooh, what did I do? There we go. So first of all, why are we talking about this? Why is there a busy heart hospital in Arkansas? So cardiovascular disease remains a massive public health problem in the United States. It's estimated that over 85 million people in this country have at least one form of cardiovascular disease. We're doing better. These numbers are improving from year to year, but we're still not quite where we need to be. There's certainly room for improvement. It's estimated, again, that about a third of people dying in this country will die from cardiovascular disease, and that surpasses cancer, lung disease, and everything else you can think of. This is an even bigger issue where we live. Arkansas, unfortunately, is among the top 5 states with the worst cardiovascular mortality in the country, so there's plenty of work to be done around here. So here's what we're planning on covering today. We're going to talk about what is PET-CT, what are its clinical applications, primarily focusing on the cardiac patient. We're not going to go into oncological and infectious disease applications. And then we're going to try to compare the PET versus SPECT, which SPECT being the traditional nuclear scans that we're used to ordering and reading. So what is a positron? So the positron is basically the counterpart of an electron. It's a positively charged particle that has the same mass as an electron. In cardiac imaging, for the most part, we're going to be using a tracer called rubidium. This tracer goes through a beta decay, so its nucleus emits a positron that collides with an electron. They're annihilated, and from that annihilation event, 2 photons, very high energy photons, are emitted in opposite directions. Because 2 photons and not 1 photon is emitted, as opposed to the SPECT tracers, you can calculate the position of that annihilation event inside a patient, primarily in the patient's heart in this case, with a lot more precision than you can with the traditional nuclear medicine camera. So just a little bit of physics, and that's the last physics slide you guys are going to see today, I think. These photons are very high energy, so they have 511 keV as opposed to 140 keV for technetium, which is a tracer for SPECT studies. This results in less attenuation and a higher quality data for processing. Because there are 2 of them, you don't need a collimator. You can pretty much calculate where that event occurred by timing, so that you're only considering opposite events that happened at the same time. This offers a higher spatial and temporal resolution for the scans. Because these photons are high energy and you're not wasting any of them with collimation, you're able to give a smaller dose. So you expose your patients to less radiation. For the average PET-CT for myocardial perfusion, you're going to be exposing your patients to 3 to 6 millisieverts. For the equivalent SPECT study, you would be exposing them to 10 to 13. Basically, every PET that's done in the country is coupled with a CT, a traditional sort of X-ray based CT. So you're going to fuse the 2 images. You're going to fuse the images from the PET camera based on the tracer, based on those photo annihilation photons that are emitted, and you're going to plot them with the CAT scan, and that will allow you to calculate how much attenuation each photon has suffered. So if you're imaging a woman with large breasts, you're going to be able to correct the energy for any photon that would have gone through that. If you're imaging a man with a large belly, the same thing. So you're virtually eliminating breast and diaphragmatic attenuation, which are the biggest sources for false positive studies in cardiology. Because you're doing that cardiac CT to begin with, without contrast, but still imaging the heart, you're going to be able to give give some anatomic information to the patient. So you're going to be able to see coronary calcium. So even in someone who undergo a PET and you may not find obstructive disease, you may find normal myocardial perfusion, you may still be able to counsel that patient if he has coronary plaque. You can tell them they have a significant burden of coronary atherosclerosis, and even though they may not need a cath, a PCI, or CABG, they still need to work on lifestyle changes and sometimes preventive medications to minimize their future risk. So just sort of coupling all that, coupling the enhanced performances of rubidium as a tracer, of the PET camera as a capture system, and of the combination of CT and the nuclear study, you get better test performance. So this is a very large meta-analysis with over 11,000 patients. You get higher sensitivity and higher specificity of PET compared to SPECT. So that's going to result in a lower incidence of false positives and a lower incidence of false negatives. In other words, you're going to be missing less disease, and when you find disease, you're more certain that there truly is an epicardial obstructive lesion in the coronaries. How does that compare with cost? I mean, PET is more expensive than SPECT, but because you get less false positives, you're not doing as many coronary angiograms. Because you're getting higher specificity and sensitivity, the coronary angiograms you do are more likely to lead to revascularization. So here, in the group that underwent PET instead of SPECT, you had much less diagnostic coronary angiograms, but a roughly similar number of interventions. So you're not missing disease, but you're subjecting less people to an invasive procedure. So with that 67% reduction in the false positive rate of perfusion studies, you end up with a lower cost. The cost for the PET strategy was roughly half of the cost for the SPECT strategy. Here are some other applications of PET. In addition to giving us that perfusion image that we're used to looking at on a SPECT test, you can actually quantify coronary flow. So that allows you to calculate coronary flow reserve. So in other words, even in the absence of an obstructive coronary lesion, the type of lesion that would be treated with a stent or a bypass surgery, you can detect microvascular dysfunction. You can detect endothelial dysfunction, and that may allow you to treat someone who has angina but no obstructive disease, but it may also allow you to better prognosticate your patient that may not have an obstructive coronary lesion, but from endothelial dysfunction may still have a higher risk for adverse cardiovascular events. You can use it for viability, and that's a great use of the PET technology. You can use different tracers to image metabolism of the myocardial tissue versus perfusion. So in this case, you have an area that does not get enough blood flow. This may be in the territory of a chronic total occlusion, for instance. But when you study the metabolism of that area, that heart muscle is alive. It can be salvaged through a PCI or a bypass procedure. You can also use it to pick up inflammation. So you may have a patient with positive blood cultures, you don't know where it's coming from, and you may have patients with artificial tissue in their hearts, artificial valve or a pacemaker. And with PET, you can image looking for inflammation in those tissues. So you can detect infective endocarditis of a valve or of a pacemaker. And this is sort of what we're seeing here. Increased uptake here in the artificial valve and here in the pacemaker pocket and leads. This is a sort of a still investigational application of PET technology. Even though some of these coronary lesions may not be obstructive, may not be affecting blood flow to the heart muscle at rest or stress, those plaques can still be unstable. They can still rupture and cause a heart attack. So this is trying to better quantify that future risk for an individual lesion. It's not going to give you just a stenosis percentage, but it may give you the level of inflammation in the plaque, which really correlates with the chances of that resulting in a future acute coronary syndrome. It's not something we do on sort of regular basis. It's not something that's been approved for clinical application, but there's a lot of study being done in this area. We can also use PET to detect infiltrative diseases of the heart. So sarcoidosis is a relatively common disease, can affect your lungs, your lymph nodes. It's often hard to determine if it's affecting the heart muscle or not. MRI is actually pretty good at that, and PET is also pretty good by looking at a pattern of mismatch between metabolism and perfusion. So sort of summarizing and basically what the take-home points of this talk should be, PET has several advantages over SPECT. It results in lower radiation exposure. The image acquisition is much faster because the half-life of rubidium is much shorter than that of sestamibi. You can do the stress and rest images basically back to back. You don't need to send the patient out for a snack and bring him back in 3 hours to re-image them. Within a few minutes, your patient will be in and out of your office. You get some anatomic information from CT, which helps you counsel patients who may not have obstructive disease but may still be at risk from a high burden of coronary atherosclerosis. And you're going to get higher sensitivity and higher specificity, allowing better utilization of coronary angiograms and coronary revascularization strategies. That's it. Thank you.